Career Award in Primary Care, American Diabetes Association. His areas of interest are precision medicine, disease surveillance, and data solutions for public health. His talk today is on precision medicine for diabetes management.
Everybody, my name is Jithin Sam Varghese. I'm an assistant professor at the Emory Global Diabetes Research Center and the Huber Department of Global Health, the Royal School of Public Health at Emory University. I thank the organizing committee of the Medicine Annual Conference for this opportunity to speak to all of you. So the title of my presentation is Advances in Precision Medicine for Type 2 Diabetes. And I would like to reframe this as a question, which is how do we make diabetes care more precise? And as you have noticed, I have added two superscripts. First, in terms of diabetes care, I mean prevention, screening, diagnosis, treatment, control, and prognosis. And by precise, I mean reducing the variance in estimates of interest via either larger data sets or through better definition. Now, ideally, all of us want clear separations for easy decision making. We want to know what we should do under different scenarios. And these are density plots of three particular distributions, each with a mean of mu. So you have mu1, mu2, and mu3. And you have the variance within the group, which is a measure of spread. And you have the variance between groups in terms of how different their means are. And what we know is that we want to maximize the variance between groups and minimize the variance within a group so that at the end of it, we know how to decide which treatment should be given for each specific group. However, the reality, as all of you physicians know, is that diabetes is way more complex than that. We have several types of diabetes, like type 1 diabetes, type 2 diabetes, monogenic diabetes, and gestational diabetes. But also we have certain forms of diabetes or certain phenotypes of diabetes which tend to overlap with each other, such as the LADA or the latent autoimmune diabetes in adults and the ketosis-prone diabetes. Now, how do we understand this variability and how do we achieve the clear separation? The goal can be achieved through representative studies where all the variability in the cases are sufficiently captured. And once we capture this variability, I think it is also important to understand the biology of cases and to know the difference between signals, which are the real variabilities, and the noise. Prameha is a concept of great importance to this field and was conceptualized by this physician, at least in recorded history, Sushruta, who lived between the 7th and 4th century BCE. Pra stands for excessive quantity and frequency of and driven by turbidity of urine, which is also indicated through albuminuria, as clear, slightly cloudy, opaque, or flocculent. And Meha stands for watering with reference to the human body. And Prameha was broadly categorized by Sushruta as one of Sahaja Prameha, which is hereditary, and acquired forms of diabetes, which is Apatya Nimittaja Prameha. Now, Madhumeha is diabetes mellitus, and Madhu stands for honey, and Meha stands for watering with reference to the human body. Now, diabetes mellitus, when you think about the different variability which is inherent in the field, can be classified into endotypes, which are a biological classification. And diabetes stands for polyuria, mellitus stands for sweet, and endotypes are some form of variability driven by biological mechanism. Now, this classification was predominantly done historically as endotypes and phenotypes. And endotypes are a mechanistic classification, and phenotypes are driven by clinical presentation. Phenotypes are often represented through disaggregated forms of or subtypes of individuals of similar clinical presentation, and typically accomplished through data-driven methods or clusters. Now, machine learning-based classification of new diabetes cases has been going on for the last decade or so. But what came to light recently, or through a study published in 2018, led by Dr. Emma Alquist and team out of Sweden, was that when they combined a group of individuals from a cohort study of newly diagnosed diabetes, of type 1 diabetes, latent autoimmune diabetes in adults, and type 2 diabetes, they discovered 5 clusters, which were severe autoimmune diabetes, severe insulin deficient diabetes, severe insulin resistant diabetes, mild obesity-related diabetes, and mild age-related diabetes. The variables that they use are typically variables which you may measure physiologically and which have physiological relevance to diabetes, such as the presence of GAD antibodies, age, BMI, HbA1c, HOMA2B, and HOMA2IR. What I wanted to mention also was that these variables, the HOMA2s, are not typically measured in clinics because fasting measures are not collected for most patients. So less than 1% of patients have this variable. Now, what Dr. Alquist and team found were that these 5 clusters differed in the clinical presentations. So for example, the severe insulin deficient diabetes had the highest A1C at diagnosis. The mild obesity diabetes and the severe insulin resistant diabetes had higher BMI than the other clusters. The mild age-related diabetes was the oldest, and the mild obesity diabetes was the youngest. The severe insulin deficient diabetes had the lowest HOMA2B, and the severe insulin resistant diabetes had the highest HOMA2IR and also the HOMA2B. Dr. Yagnik and team, based out of Pune, replicated these Andes subtypes using the Welgen cohort in a sample size of 1612 individuals. And what they found was that the severe insulin deficient diabetes was more common in the Welgen cohort as opposed to the Andes cohort. So which constituted roughly like 53% of the total sample. Now, we spoke of these 4 subtypes: the mild age-related diabetes, severe insulin deficient diabetes, severe insulin resistant diabetes, and mild obesity diabetes. They varied in the prevalence of complications. Now, the mild age-related diabetes and the mild obesity diabetes had the lowest prevalence of retinopathy, while the severe insulin deficient diabetes and the severe insulin resistant diabetes had the highest prevalence of retinopathy. The mild age-related diabetes and the severe insulin deficient diabetes had higher prevalence of nephropathy, and the mild obesity diabetes had the lowest prevalence. Dr. Mohan and team from the Madras Diabetes Research Foundation conducted the INSPIRED study of 19,000 individuals where they identified 2 novel phenotypes or novel subtypes. Apart from the mild age-related diabetes and the severe insulin deficient diabetes, they identified the insulin-resistant obese diabetes and the combined insulin-resistant and deficient diabetes. Beyond looking at prevalent complications, they were able to look at risk of microvascular complications, which are new complications. And specifically, what they found was that relative to the mild age-related diabetes, the severe insulin-deficient diabetes and the combined insulin-resistant and deficient diabetes had a higher risk of retinopathy. Furthermore, the CIRDD, the combined insulin-resistant deficient diabetes, had the highest risk of chronic kidney disease, followed by the IROD and the SIDD. They also made some initial attempt to study treatment response in terms of changes in HbA1c for metformin and insulin and a host of other medications, but the clinical significance of these findings were small. Nevertheless, a lot of these studies were conducted. There were a lot of replications being done, but a major gap remained in terms of how do we translate these subtypes to clinical practice, especially in the US, when key biomarkers, which are fasting insulin and fasting glucose, are routinely measured in less than 1% of the sample. Jongyu Lee and I and our team at Emory, we replicated the Andes subtypes using 6 cohorts in the USA. And as you can see, the clinical presentations are very similar to what is observed in the Swedish cohort, where we identified the 4 subtypes of newly diagnosed type 2 diabetes. The severe insulin deficient diabetes had the highest A1C. The mild age-related diabetes had the highest age. HOMA2B was lowest for SIDD, and HOMA2IR was highest for SIRD. Now, applying these subtypes to electronic health records using machine learning models revealed geographic and sociodemographic variations in proportions. So what we observed was that even within different states in the US, in a sample size of 727,000 or 7.2 lakh patients, the proportion of newly diagnosed cases that were severe insulin deficient were higher in some states where the proportion was over 20%, and lower in other states where the proportion was under 15%. Furthermore, the proportions of severe insulin deficient diabetes was in general higher among non-Hispanic Black and Hispanic patients as opposed to non-Hispanic white patients. So this, we felt, were the initial steps towards how precision medicine can be combined with public health. Next, we also looked at mild obesity-related diabetes and mild age-related diabetes. And what we observed were that the proportions of mild obesity diabetes tended to be higher, especially in populations which were more minority dominated. And mild age-related diabetes was more common in populations which are more non-Hispanic white dominated. But one major challenge remained, wherein we knew that the severe insulin deficient diabetes and the severe insulin resistant diabetes were at higher risk of certain complications, but we did not know how they were related to mortality. So in a sample of 2,500 individuals from a nationally representative data set in the US, Krishna Sanaka, who is one of the brilliant undergraduate students who I worked with at Emory, found that overall all-cause mortality was not very different between the subtypes, but heart disease mortality was higher for the SIDD compared to the other subtypes, while cancer mortality was higher for the insulin-resistant diabetes compared to the other subtypes. Now, what are the potential implications of the Anders subphenotypes for clinicians? Now, this is a perspective article which was published in 2021 by a group out of Japan. And what they said was that certain subtypes may be more benefited from certain kinds of medications. However, these were all posited, they were theory and they were not tested. And I highly encourage you to go through this paper for some of their initial intuitions, as opposed to what phenotypes may benefit from what treatments and what lifestyle interventions. Till recently, we did not know, and this was not verified through a clinical trial, but like a specific trial, which was a small trial of about 240 patients, was conducted very recently and published in Nature Metabolism, where they randomized SIDD and SIRD to a GLP-1 and an SGLT2 inhibitor. And what they observed to a large extent was that majority of the response in treatment, especially for A1C, could be driven could be explained by the kind of medication they were prescribed. So, for example, what we see is that semaglutide showed a higher effect, a higher potency for both SIDD, which is insulin deficient group, and the insulin resistant group, SIRD. Furthermore, where you start off also matters in terms of how much you drop. And what the study showed was that there was a sharper drop in SIDD, which typically tends to have higher values of glycemia. And what we observe here was that the semaglutide group in SIDD exhibited a greater change, and the semaglutide group in SIRD also exhibited a greater change. Now, what did all these different studies find? As I said before, several people have replicated this. And to our last count, at least 60 studies have found these subtypes in different populations, both newly diagnosed and existing diabetes. Consistently across Asians and non-Asians, what we observed was that the mild age-related diabetes tended to be more common. However, in Asian populations, the SIDD group, the insulin deficient group, tended to be slightly more common than insulin resistant group. And in non-Asians, the insulin resistant group tended to be slightly more common than the insulin deficient group. But what is even more interesting is that when we started taking apart these specific mean values of these different studies, what we observed was that the averages also tended to be very different, even for what were classified as the same subtype. So if you look at the MOD subtype, the MOD subtype, what we see is that the average BMI for the median BMI for MOD across all different studies, plus indicates non-Asian, the dot indicates Asian. The average BMI was higher in non-Asians and lower in Asians. And the on average, the A1C median for specific subgroups, it tended to be higher for SIRD and SIDD among Asians as opposed to non-Asians. Now, The age also tended to be higher for non-Asians and lower for the Asians across all subtypes. Now, what this is sort of like saying is it reiterates what we know already, that Asians seem to be at higher risk at lower BMIs and at lower ages. Jiali Go, a biostatistician who I work with at Emory, she replicated these subtypes in youth onset type 2 diabetes in the USA. And what we observed was that these subtypes are present even among younger adults who tend to develop diabetes between the ages of 10 to 19 years old. Which suggests that it's probably a combination of genes and environment, like most diseases. And so there's a need to study it further and over the life course. But what do we understand in terms of causality? To a large extent, as I mentioned before, these are data-driven methods and not driven entirely by physiology. So a group out of Harvard looked at a combination of genetic markers and biochemical profiles and vitals. And what they showed were these 5 distinct clusters of genes and biomarkers. These are like beta cell, proinsulin, obesity, lipodystrophy, liver and lipid. And this other group out of Germany, they used a German diabetes study. And what they showed was that, they used the TUEF TULIP study. And what they showed was that there were 3 clusters which tended to be at higher risk of diabetes. And these were individuals without diabetes. So the top one are people with diabetes. They identified these 5 profiles. And the bottom one are people without diabetes, where they were trying to assess risk. They identified these 3 groups, and they said that group number 3 and group number 5 are at elevated risk of diabetes, that they will tend to develop diabetes faster. Now, group number 3 was characterized by higher likelihood of secretion failure and to some extent insulin resistance and visceral AUC of glucose, while cluster 5 was characterized by higher liver fat, some level of insulin resistance, while cluster 6 had a higher degree of insulin resistance and visceral adiposity. Now, what are the causes of this consistent replication of these kind of subtypes and this variability over time? Now, some of it could potentially be explained by genetics, and Dr. Nihal Thomas and team at CMC have done a lot of excellent work in this space, where they looked at early life determinants and genetic determinants of disease, especially for these rare phenotypes of disease. And some of it, like I mentioned before, could also be explained by novel subtypes which are present, primarily driven to a large extent by early life determinants, such as the lean BMI phenotype that was identified in this study, which to some extent the BMI was lower than the average BMI of SIDD, and they had poor insulin response to metabolic challenge. There is some work being done in South Asian populations, but most of the omics studies are predominantly on participants of European origin. Now, this is a study which was published in 2019, and what this says is that almost 80% of studies were conducted in European populations. And this presents a significant gap. And we did not know till recently what proportion came from LMICs, where 3/4 of the diabetes burden reside. So 2 of the undergrads who I worked with recently, they put together a large database, and they identified potentially less than 10% come from non-European populations. And we're currently using ChatGPT to classify 125,000 studies, which we think are likely related to precision medicine. Now, data-driven classification of diabetes is not new. This heterogeneity was always known as early as 1992, as a study shows, where they used area under the OGTT curve for different to identify different subgroups. But the ANDIS study, which I mentioned before, it changed a lot in terms of our understanding. And it was challenged by somebody competent to challenge it. And it helped us understand this variability a little better. And at the end of it, it helped us understand that the paradigm was ready to be shifted. And I want to end this talk with a quote that the ANDIS study challenged the dogma of type 2 diabetes being one thing and made people rethink type 2 diabetes beyond the ongoing conversation. Thank you again, and I'm happy to take questions.